I wanted to share with everyone. We really want to get to know you and who is in the room today. So we have a poll that we would like you feel comfortable sharing. It is an anonymous poll. And share where you're calling from today.
Right. So perfect. I was going to say, there's a link. Yeah, and so the link that Alyssa just shared, and we'll keep track of the number of people who join, and say this again when a couple more people join. The link that Alyssa just shared is a link to a clickable map, and so you can identify yourself however you would like, and then click on the map, and people will just see a pin of where you are. And I think we're going to share that map so we can see when people do that.
Yes, I will go ahead and share that now.
I'm getting a note that the poll is full. Is there a way to unlimit that?
Oh, that's not good.
Oh,
Hey,
looks like that somebody fixed it.
All right. So it looks like we have a big turnout from the US today, also from Europe and from Africa. Welcome. I always love being in these spaces and seeing where folks are coming from and calling from. So we're really excited to have you all here today. So as people come in, please go ahead and share where you're calling from. We will get started at 10:05, just so we can let people roll in. But once again, thank you for coming in today. My colleague Nicole has posted in the chat our session's agenda, our objectives, as well as speaker bios. So if you want to go ahead and see who's going to be speaking today, what we're going to be speaking about, you can go ahead and click that link and it'll take you to our flyer for today.
and along those lines, two more quick announcements, and then I think it's 4 minutes after, so we'll kind of move towards getting started soon. One of those announcements is that CUGH has given us folks the email addresses with which folks registered, so we will be sending out a link to a collection of slides and such later. And the second announcement was, just on the bios, we're going to try and save time by being as brief as possible with introductions. So please refer to the handout to find out a little bit more about where people are from and so forth. And then to repeat two more things that we said earlier for those who've joined, Alyssa posted a clickable link to this clickable map, so you can click on that link and post your location. I'm going to repost both of those links for those who might have come in late. And Nicole posted a link to the handout. So we'll repost those and re-announce those periodically as people join. But I think we've got everybody up to participant number 40 so far. So we're in good shape.
That's a pretty good number to get us started.
Right. So I would, I'm Bill Lober. I briefly introduce my colleague, Mohsen Malakinjadad, and I believe we'll just start.
Thank you, Bill. Let me turn off my screen. Good morning, good afternoon, good evening. I'm sure we have all kind of the time zones in between. I'm Mohsen Malakinjadad. I'm a professor of epidemiology and global health at University of California, San Francisco. Welcome, welcome, welcome. Thanks for being here. We are going to be, Bill Lober from University of Washington and I are co-hosts in this session, and we're excited for having a productive and fruitful conversation about the future of this technology, digital exposure notification. I'm going to do just a few level setting slides, just to make sure that for those who may or may not have a closer kind of or intimate relationship or work in the space of exposure notification, just getting a little bit of background information that may help better understand what the discussion is and framing of what this conversation is going to be about. So as we all experienced the pandemic as it was unfolding, especially at the beginning, we didn't have too many options to respond. We had masking, we had ventilation, and we had also contact tracing, which would help to mitigate the spread of the infection. But we all know that how contact tracing was labor intense, required a lot of trained public health workforce, and not the most efficient way of letting people know who've been exposed. And around that time, one of the thinking was, how can we actually make that process a little more efficient? And in that context, some technology partners developed technologies that would allow use of a smartphone to use that to be able to, for those who've been exposed to, for example, the COVID-19, those who got the disease, be able to notify others. Apple and Google developed a new technology that was called Google Apple Exposure Notification, GAN, which was introduced around April of 2010. That technology was pilot tested in Switzerland. In subsequent months, other countries gradually took advantage of that technology. And here in United States, in California, we pilot tested that technology in different version of that, which we call the Exposure Notification Express, in September of 2020. And after that, other also states in the United States implemented some version of that technology. Now, what this was essentially was an improvement over some other existing also ways of notifying those who've been exposed. The GAN technology that I was explaining, the Google Apple Exposure Notification, took advantage of Bluetooth signal to use that signal to estimate the approximation of two phones and use that as a proxy for how two people could have been close to each other and notify those who've been around the person who tested positive and used the system to trigger a notification. The advantage of this new technology was that protects users' identity and was privacy preserving. We're going to have a conversation a little bit more about this issue. It didn't also capture the specific time and location of exposure. While that was helping to improve the adoption and people's trust in the system, there was also disadvantage. There was always a balance, trade-off, and that made it harder for us in public health to be able to better evaluate how the system works and kind of having a more strong and rigorous analytical capabilities. Just to explain how this Bluetooth-based application would work, the user should activate it on their smartphone, and then one of the users is in close proximity with another user. The two phones would exchange certain keys they're digital kind of keys. And if one of those users tests positive for COVID-19, then they're receiving a code that they could use to send a notification to other users who have been around them. And the user that were near the positive case during the infection period, that that person was infectious and could transmit the infection to others, then they would get a notification, and then they'll be given information about what they should be doing next once they've been exposed. Behind the scene, behind the application, there was a simple risk model, mathematical model that would take into account the distance, which was essentially using the Bluetooth attenuation range, and then also how infectious the case was by closeness of that person to the date of symptom onset, the duration of exposure, and overall coming up with the weighted time that the public health authorities could use to set who should receive exposure notification and who should not. User would not necessarily see this this mathematical. This was happening behind the scene. Now, it's hard to say. We did a landscaping review early in 2021, and we found where in the different continents, different countries, some form of exposure notification was implemented, and there was 80 regions, several countries, and several millions of users perhaps took advantage of this technology. The Google App Exposure Notification API was disabled in September 2023, and we felt that given there's so many countries, so many regions implemented some version of this technology, it is a good time for us to get together and think about how can we better distill the lesson learned from this implementation and inform the future of this technology for future respond to other outbreaks and infectious diseases. So with that, I'm going to just in a minute hand it back to Bill, but also want to share with you, and we're going to talk a little bit more about this later in the day. But with this thinking that better understanding of what worked, what didn't work, and being able to more systematically collect the evidence about the implementation of exposure notification, we're designing a survey to help set policy priorities and inform design of EN technology. And we are going to deploy this Delphi survey in a few days. And we would love to have participants who might have been engaged with implementation of exposure notification evaluation or provide provision of technical support during the pandemic participate. And in order for you to participate, you can either use a QR code or a URL that is, I think Elisa has put in the chat. And this survey would be confidential. We're not going to be revealing the specific location of the participants, and data will be only shown in aggregated form. Again, we're going to be talking a little bit more about the survey, and you hear more details of that, but I just want to make sure that for people who are staying now and may not stay all the way to then, we would love for you to stay. Just have an opportunity to hear about this survey. Bill, I think you're up next. And I'm happy to advance your few slides.
That sounds great. So the Alyssa just put the link to the Delphi survey in the chat. I'm going to, since we still have a couple of people who've joined since the last time I posted, I'm going to post one more time the link to the handout for today's session, which contains all the biographies and some other information, as well as a link to an interactive map that Alyssa displayed earlier, and which will show again during the break, showing where people are calling in from. It actually is a pretty widely distributed group, which is interesting. So Mohsen provided a brief intro to exposure notification, and the final thing is that we'll be sending out a link to slides for all who registered. I wanted to tell you very briefly how some of us know each other and why we decided to have this virtual session. In the US, the choice of whether and how to implement exposure notification was at the state level. A few of the early implementing states in the West started meeting to exchange ideas, much as we're doing here. And without any support or guidance from our national government, this group kind of grew to include the 17 dark green states and the District of Columbia, our national capital region, on the map. So there's a link you can look at here for the Digital Notification Alliance group, but many of us are on this call, or many of us who are still active are on this call, and one purpose of the meeting is just to expand the voices that we hear, the experiences we share, and the people that we know, in case it becomes advisable to revive something like exposure notification again in the future. Everybody lives in their own political context, in their own world, and there's not a lot of appetite for talking about COVID or talking about technologies that were used in COVID right now, at least in the States, or at least in some narrow circles that we're part of. But we think that the overall idea of thinking about ways that smartphones can provide personalized risk is the poll is full again, crazy. Anyway, thinking about the ways that smartphones can help provide personalized risk assessments for people and personalized public health messaging. I think that's kind of remains a pretty fascinating area, and springboarding from our experience with exposure notification is, I think, a good idea. So next slide. What are we doing today? If you want to advance the slide, Mohsen. Yeah, thanks. So we're in the quickly getting to the end of the opening remarks. We're going to have a group of speakers talk about their perspectives from several different countries. We'll ask you to do a short evaluation as a Zoom poll, and we're going to claim that evaluation is a break. We'll have a few more shared experiences from several of the West Coast DNA members. And then we're going to do another brief break and a Zoom poll to assess how many breakout sessions we should create for discussion and what topics those sessions are going to be on. And then we'll have a couple of quick talks about ongoing research and what we perceive to be the value of exposure notification, or what we perceived to be the value of exposure notification in COVID and perhaps going forward. I wanted to close with some additional comments about we're excited to have a chance to do this virtual session. Presumably everybody knows that CUGH is about 4 or 5 months away, and we're planning a panel for that meeting. It'll be in person, if you can imagine such a thing. We plan to take a broader look there at the context of EN, how it was used, and how extensions to those technologies might help with this notion of personalized risk and personalized behaviors. We also, I touched earlier on 2 other ideas. One is to help us all identify interesting learnings from the use of EN in COVID, not just in the US, and not just in the US and not just in Europe, but Mohsen's map showed shadings in quite a number of areas around the world. And so, whether your interest is in technology, in the implementation of that technology, or in measuring its impact, there's information to be shared. And then the other idea that I touched on was expanding the community of people who are knowledgeable about the technology and the experience of using the technology, as well as about each other's skills and interests. So CUGH gives us a great way to extend our reach outside of the US and Europe, and we're anxious to do that. Finally, one more thing I wanted to mention. Mohsen and I are both part of the Resilient Collective. He mentioned that earlier. I put a link at the bottom of this slide. And you can kind of read the brief blurb about what it's about. I think Mohsen has a couple of additional words about partnership, on which we're going to close the opening remarks, and then we'll get on with our first set of speakers. So all yours, Mohsen.
I think I was on mute. Thank you, Bill. So just, I don't have the slide, but I do want to just acknowledge that none of the work that we all did, at least in the United States, was possible with the partnership that we had with both technology companies, Apple and Google, who developed the technology to begin with, and also many other partners such as MITRE, APHL, other state health agencies, university partners, and many, many more who made it possible for us to learn about the new and novel technology that possibly could be used for future of outbreak response. So without getting too much of details, and I know that this is going to come up for each presenters or others who have their own kind of local partners and within their own jurisdiction who may want to acknowledge. I want to move to our first group of speakers, which we have from 3 jurisdictions joining us. Again, as Bill mentioned, the bios of our speakers can be found in the handout that we distributed. The 3 speakers we have, Marcel Salate is the digital. He's going to talking about the digital contact tracing and why decentralization matters. Will Steele is from District of Columbia in United States, and we'll talk about the public perceptions and post-exposure notification actions within the DC area. And Wolfgang Ebers, he's going to talk about what's so crucial that we need to ascertain EN effectiveness and learning from the CUGH contact tracing application. Before I pass it to our first speaker, I just wanted to also mention that we are at the point that there's a lot needs to be learned and to be done. During the course of the pandemic, it was very hard for us to really sit down and do the type of evaluation that we do usually for other types of public health interventions. The evidence about the effectiveness of this technology has been growing, but mostly relying on the mathematical models for a variety of reasons, including some of the limitations of the way that the data is being collected, or limitation of the technology being privacy preserving. Without kind of thinking about this is just a handful of a few modeling studies from different jurisdictions, without kind of paying too much attention to the specific magnitude of effect or how many cases been averted, one thing that can be learned is that the direction is positive. There's some promising at least attributes to this. We can take advantage of this technology for the type of outbreak response, but of course a lot needs to be learned and a lot needs to be done to really better understand the how much effective this technology can be. I think we're in this kind of juncture that we want to better learn, collect this evidence and learn what we have done, and being able to have a constructive discussions about how can we move forward for the future. So I think I went too far. I'm going to hand it to, let me stop sharing screen. And I believe that our first speaker is Marcel.
Yep. Thank you very much, Mohsen and Bill, for the invitation. And I'm going to share my screen. And while I do that, let me just nevertheless note that I think 2 of these 4 studies you've shown are very much based on data. There is some modeling, of course, as well, but certainly the study from Switzerland and from the UK was based on data. So I'm a digital epidemiologist. This means I'm an epidemiologist, and it also means I love data. And this is something I always say in the beginning kinds of talks. People think I'm a privacy person or an ethicist. No, I love data, right? I love data for public health. So keep that in mind as I give this talk. So the reason why I'm very careful, though, about data is not just an asset. I think when it comes to perhaps particularly true, the HHS has this nice breach portal. You can see here a screenshot that I took actually just today from the last couple of days. You can see this is not looking good. You can download the Excel file there. And what you find is that in 2023 alone, the data of more than 70 million Americans has already been hacked. And this is probably, well, I don't want to say this is the tip of the iceberg because it would be a very large tip. It's certainly a big part of the iceberg, but there's certainly also a part underneath this iceberg. So data that you store centrally, you must assume it will eventually be hacked. And these are not beginners here. We're talking about big companies, big health systems that probably have serious staff efforts to make sure this data doesn't get hacked, and still it gets hacked. So we have a particular responsibility here. Then people often say, well, this is all very sad and so on, but, very sorry, we need the data because, you can have one of the two. You can have privacy or you can fight the pandemic. You can have privacy or you can have good digitization. You can have privacy or AI. That's the current flavor. These are always false choices. And I definitely want to underline that they're always false choices. And if you don't take anything from this talk from me, then please take this with you. That if you're offered such a choice, it's mostly, almost exclusively a false choice. So you have already introduced how digital proximity tracing works. I don't want to go into the detail here, but the way basically, right, this works is it's sort of a notebook and a logbook of phones in close proximity to each other. And when the pandemic started, so around February, some of us at DPFL got very nervous because we were exactly exposed to this idea that, well, you know, privacy is a nice thing, but we're now looking at a pandemic, so please, right, privacy needs to move over. And we said, you know, this is a false choice. And can we come up with a technology protocol that can reach the goal that you want to reach, which is to notify people of exposure without giving up privacy? So what we proposed was a decentralized framework. Now, why does it matter, and what is it? So at the end of the day, right, there were many groups around the world that had different ideas. And by and large, you can group them into two camps, the decentralized camp and the centralized camp. Now, what's the difference? So here's very simplified, right, how the central model works. So this person here, person A, who has been in contact with B, C, and D, is now sick. And so what happens is, well, you're now going to disclose, right, the contacts to a central server because you need to know, right, who was exposed. And then you will inform these people. So B, C, and D will get a contact and exposure notification. This seems all very natural and logical, and that's how most people do things most of the time. The problem with that, of course, is you have a central server here that is now starting to get a lot of really difficult data, right? Difficult in the sense of very privacy concerning data. Contact information is possibly one of the most sensitive information you can have. And in particular, right, if that's not enough, I mean, another big issue is that really the users eventually lose control over data, because once that contact data is out, well, you can later not just regret having shared it because it's still there. Now, of course, right, governments and so on would then say, well, no, right, we have laws and you can trust us and so on, but this is what we call privacy by trust. And as we've seen, this doesn't often work. And, you know, you may trust your government, but many people on this earth are not in such a lucky situation. So the question was, can we build something that's privacy by design, not by trust, right? And that was the decentralized model. So the decentralized model starts from the same premise. There's a person A that's been in contact with B, C, and D, and now they're sick. So what are we going to do? Well, we're not going to share the contacts. We're just going to share the fact that this person has now a positive test. This is per se not such a sensitive information. The person has already gotten a test somewhere. They're probably already in some kind of system. I'm not saying it's nothing, but you know, it's not contact data, and that's this contact data is much more sensitive. So now, what do you do with this information? Well, as you can see here, you still have a central server, but the central server is just sort of a, you know, a pass-on server. It doesn't actually it's not able to really infer any network information. Now, unfortunately, and that's the downside technically, it has to share this information now with all the phones in the system, and this easily can be, you know, dozens of millions of phones or even more. So, you know, from a bandwidth perspective, this is certainly not quite as ideal as the other model, but you do the calculations and you realize, okay, this is still possible, right? It's as we've seen. Now, everyone gets the information that A and now they exposed, whether they have A in their logbook, so to speak. So the key difference here, right, is that the decision making, which needs contact information, does not happen on the central server. It is decentralized to all the phones. And that has extremely good privacy guarantees because it is on millions of different phones. So yeah, this is what I just said, right? This is all then done locally. Now, centralized privacy preserving proximity tracing model. We know from different, but also in the end some public sources, that this was eventually into the exposure notification framework. If you analyze it technically, it's by and large the same thing. Some few slight differences, but by and large, we were of course quite happy to see that happen. Now, there were of course some apps that were centralized. Also, when you then later had apps, right, where people could scan QR codes, for example, if you would go to a restaurant or so, those would centralize the data. And no case of misuse that I have come across was on centralized app. To the contrary, I'd love to hear it because I'm making a fairly thorough list here, but I am not of any misuse or data loss apps, and I don't think I'm wrong about this or that I'm missing anything, because that's the point of this technology. You draw the line in this, not with some big centralized security apparatus or with having to trust someone, but because virtually impossible to do that, right? This is privacy by design. So as has been mentioned in the beginning, of course, it's not all sunshine. You are in a trade-off situation here is that you don't have a lot of data, right? Because you're not collecting it. That's the beauty of being privacy preserving. But of course, now if you go to tell him or her, well, so did this work? They will say, well, this is tricky, right? Because we don't have the data. So how do you do this? Well, there are ways, and the WHO and the ECDC a framework to evaluate this. It's just not as straightforward, but it is certainly possible, as I'm sure we'll hear from other speakers down the line as well. I myself have written up some of that in a recent comment in Nature. I'm heavily, of course, leaning also on the data here from the UK, which I'm sure you've seen in two beautiful Nature papers, or one in Nature and one in Nature Communications. This is Chris Fraser's group, which has shown very convincingly, right, that they managed to avoid tens of thousands of hospitalizations and about 10,000 deaths cases just in the, and all with very little participation. 20% at max 25% of the UK population participated, which I think is roughly in line with what we also know from other countries. So you've shown this graph that Chris's group developed that showed, for rough % of additional usage, she would get another 1% prevented. And one does not need to be an advanced mathematician to know what this means. And in this context, right, I am very disappointed is probably the most diplomatic term that I can find, that this technology is not on pandemic plans, right? It just doesn't figure there. And I think if we're not, if we don't manage to put in this data, then I cannot use any other term but a public health failure, an extreme miss that would really make me question a lot of things. Now, I want to end by saying clear tech, right? And I think we'll here that even your best technology will fail if it is not well integrated into a digital pipeline also. And then of course, everything trustworthy communication and all of these things. And if I have one regret looking back, I would just had hoped we had a little bit more time and bring in so many more disciplines on, right, with making this logical perspective and so on. We were caught off guard, but now we do for the next pandemic, and so this should really be at the top, among the top priority of pandemic preparedness plans. Those are my 5 cents. I thank you very much.
Marcel, thank you very much. Important, maybe it's a heart of the matter, basically, to me. That, you know, this is one of the, at least, main reason that we're here together, to very basically reflect on those thoughts. We're kind of come back to if there are any questions to the end of this section, but I would like to move to our next topic, who is, we're coming back from Europe to United States in the East Coast, and Will Still from District of Columbia is going to present. And I think you're on mute.
Yes, am I unmuted now? Can you hear me okay?
No, you're good now. Please
Awesome.
take it away.
Give me just one quick second. Sorry, I'm just trying to get into, okay. Should be good now. Perfect. Thank you so much. Hello, everyone. My name is Will Still. I'm the data team lead for a group called the Outbreak Investigation Team within DC Health. And I've been the DC CAN lead since over the last 3 years or so. And so it'll be my pleasure to speak with you all today about public perceptions and post-exposure notification actions, some lessons learned from our DC CAN application. So our objective today is to evaluate engagement, public perception, and utility of our DC COVID Alert Notice, or DC CAN app, the District's Exposure Notification app. We initiated it in October 2020. We were one of the first jurisdictions to utilize this digital health tool in the United States. And by the time exposure notification systems were sunset in the United States in May of 2023, we had over 2 million cumulative devices opt into DC CAN. We had 40,000 people, an estimated 40,000 people use DC CAN to share a positive COVID-19 status, resulting in over 1 million estimated exposure notifications generated. So the bulk of the data we'll share with you today comes from our COVID check survey. So whenever a DC CAN user receives an exposure notification, they receive an anonymous link to our survey, and based on those responses to several questions, they receive tailored guidance in alignment with CDC recommendations and those guidance were evolving as CDC guidance evolved as well. So all respondents, by the end of the program, all respondents were advised to monitor for symptoms, wear a mask around others, get tested, and if they were feeling ill, to isolate, quarantine. So we treated this as if it were an exposure, and then we issued guidance as such. And so the survey was revamped and expanded in January 2023 to facilitate the collection of many additional data points like demographics, planned post-exposure actions, and attitudes or sentiments towards DC CAN. And again, this is all de-identified. There was no personal information that we collected. And these are our sort of aggregate results from some of these analyses. So overall, we had 4,217 responses between January and May. Again, January was when the survey was revised to the most updated iteration, and May 11th was when we sunset in the United States. So this represents an average of 37 user responses per day during the time period. And survey responses sort of declined steadily from January to May in accordance with case trends that we observed in DC. So I should take a step back and just note that it's really interesting to have some of these data, because again, it is so important to have the system be as privacy preserving as possible, but it is also really interesting to gain some insights into who is using the app, and the survey data is sort of a proxy for that kind of information. And so the figures here present the demographic distributions of survey respondents by race, ethnicity, by gender identity, and by age group. So you can see that most survey respondents were non-Hispanic white at 63%, followed by non-Hispanic Black or African American, and Hispanic. Nearly 60% of respondents were female, followed by 37% male. I will say that we do have a slightly higher number of females than males that residing in the district, but not quite that high. And the most common age groups of respondents were 25 to 34 at 32%, and 35 to 44 at 28%. So the majority, or 60% of respondents, were between the ages of 25 and 44. Less than 1% of respondents were under 18, and just under 15% were 55 or older. So this, again, provides a snapshot or some sort of insight into who's using DC CAN in 2023. And I know this Yeah, so this is a sort of map of DC. This graphic displays a proportion of survey respondents by residential ward. DC is divided into 8 wards with approximately equal population sizes. So it was really interesting for us to look at this data by ward to see within DC who's using it. And we found that wards 1 and 6, sort of in the middle here. Sorry, my pointer's not on, but you can see that the slightly darker regions are where we had more, the highest proportion of survey responses, whereas ward 7 and 8 are where we had the lowest proportions. And it's nice to be able to see this so that we can target future interventions or even marketing strategies to maybe wards with lower uptake or survey responses. Another interesting find is that a lot of, that just over a third of our respondents were not DC residents. DC is a relatively small jurisdiction with very porous borders. We get a lot of visitors, and many residents of neighboring states enter regularly for work and leisure. So about half of non-DC respondents reported that they work in DC, which does suggest that some of our users may have once opted into DC CAN and kept DC as their active region. As we know, exposure notifications work across borders. So if someone lives in another state but has DC set as their active region, even if they're exposed in their home state, their notification will come from DC CAN. And so this graph here shows the planned post-exposure notification actions among respondents. So overall, 56% plan to get tested after receiving the notification, 29% plan to monitor for symptoms, 3% plan to wear a mask around others, 2% plan to isolate or quarantine, and about 10% reported no planned action. Among those who reported that they were symptomatic, which constitutes about 19% of our survey respondents, so within that 19% of respondents who were symptomatic, 9% plan to isolate. So this may actually indicate a need to emphasize the importance of isolation when feeling sick to reduce the risk of further transmission. I will say it is also important to note that this analysis covers data collected in the spring, where people may also be experiencing symptoms related to allergies or cold symptoms and things like that as well. But just interesting data to kind of to look at. And so now I want to talk about sort of user perceptions and how our respondents felt towards DC CAN, which is always really great to take into account how the community feels about a public health intervention. So the donut graphs here display the distribution of respondents' confidence in DC CAN and perceptions of usefulness of the guidance issues. So overall, 72% of respondents reported some degree of confidence in DC CAN, with 16% reporting they were very confident that DC CAN helps reduce the spread of COVID-19. While 10% reported a lack of confidence in the app. Almost all of the respondents, about 93%, said that they found the guidance provided to be useful, with 51% reporting it was very useful, while 4% reported that it was not useful, and 3% reported that they didn't read the guidance. But overall, pretty strong engagement and user perceptions here. So we were pleased with the usefulness metrics. And then the last question in our survey is provides an opportunity for respondents to give open text feedback about DC CAN, just to kind of provide some sentiments that weren't captured in the survey. And so we compiled to some of our key pieces of community feedback that we received. So several respondents appreciated that DC CAN was still active, especially in light of other interventions being sunset before DC CAN. For instance, we of course put a lower focus on vaccination campaigns and public spaces to receive vaccines. So it was nice that this app was used in a time where other interventions were less common. And so they found it helpful so they can protect themselves and others from COVID-19. One response encouraged us to spread the word about DC CAN, especially among parents of students in schools. I will say another common sentiment that we got a lot was notifications need to come faster in order to be effective. And we do recognize that delay notification arrival occurs, with a notification arriving several days after an exposure not being as useful as notifications that might come sooner. And so we know that the timeliness of the notification does depend on when the user decides to get tested in relation to when they started feeling sick and when they were around others. So taking steps to reduce the delay between symptom onset and testing, as well as the delay between testing and going and taking the action to share their status, would reduce the time it takes for contacts to be notified. I did want to mention 3 important limitations to some of our findings. First, these findings may be subject to selection bias, as only users who completed the survey were included. So there are many DCCAN users who may have ignored or failed to complete the survey, and we will be missing their responses in this report, which may impede our ability to generalize these findings to all DCCAN users. We estimate approximately 23,000 notifications were generated during this time period, and at around 4,200 responses, we estimate an approximate survey completion rate of about 20%. Second, these findings are also limited to 2023 when we deployed the final expanded iteration of the CUGH survey. If I could do it again, I would have loved to use the survey version for the duration of the pandemic to be able to get some more visibility early on. However, we do have some data collected from our contact trace force program that does reflect some interesting usage patterns and post-exposure notification actions there. So even though this is from a different time period, it's interesting to be able to compare the two periods. And last, we were not able to follow up with survey respondents on if they actually got tested and what the result of that test was. Would have been super interesting to know what proportion of our respondents overall tested positive, so we could estimate some sort of secondary attack rate, especially among those who were symptomatic. So it would have been really interesting to be able to collect that data, and so we're keeping in mind that lesson for next time. So to conclude, we have three main findings from our analysis. First, I wanted to highlight that we have pretty strong confidence and high perceived usefulness of DCCAN, with most users confident that DCCAN was helping reduce COVID cases in DC, and again, over 90% of users finding the guidance issued to be helpful. Second, we did want to document a behavior change after receiving exposure notifications, with the majority of respondents reporting that they would get tested as a result of receiving the notification, although there is certainly room for improvement. And last, we want to highlight the urgency to explore reasons for lower usage among underrepresented populations, as it's really important to consider equity in all public health interventions. And so we did notice some certain demographic groups being less representative in the survey responses than others. And so identifying barriers to enrollment and understanding ways to improve public engagement is critical to bolster the success of exposure notification applications and reducing transmission of COVID-19 and any other diseases for which this technology may be leveraged. So last, I'd like to just acknowledge the DCCAN team, including Pamela, Allison, Carla, and Khalil, in addition to members of the DC Health leadership, including Dr. Mangla, Christina, Emily, Dr. Ayeli, and Dr. Fern and Jonathan Clark. And then I'd also like to thank our interjurisdictional partners, the DNA group, the WA Notify team for some assistance with our survey development, and our other tech and government partners. And thank you all again for your time.
Bill, thank you for the presentation. I had heard a slightly different result before, but this time around, every time I listen, I learn something new. So really appreciate that. We're gonna go back to Europe, and our next speaker is Dr. Wolfgang Ebers, who will share with us some of his insight from implementation of the digital contact tracing in Netherlands.
Thank you.
Okay, thank you very much. Thank you for having me, Mosen and Bill. Alyssa, thank you for inviting me. So a couple of miles to the north from Marcel, here from the Netherlands, in the evening calling. I will give my presentation now. Let me see. Share screen, so this should be it. Okay, well, let's see if Marcel and I still agree when I finish my presentation. So I want to dig into the question, what's so crucial that we need to assert in the end effectiveness? Just to do some surface skimming, this will take about 8 or 10 minutes max. I prepared a little agenda. I will set the scene, talk a little bit about the Dutch contact tracing application and some ballpark figures. More important, what has been the health impact of the Dutch CTA, and then we're going to zoom in a little bit on predictors of adoption and adherence. This is the Netherlands, then we zoom out again to European level and to what Christopher Fraser and I did to the Council of Europe, or in the Council of Europe, where we talked about getting a balance, striking a balance between privacy and impact assessment. Well, we'll get there later on. So first, setting the scene. as in most countries, Marcel already hinted at it, we also had a decentral architecture from our application. It's called Corona Melder. I won't bother to translate the second part of Corona Melder. It was a passive health app designed to protect the health of others, very important, and installed on a voluntary basis. In contrast to many other countries, in the beginning, we had a full embedding into the manual contact tracing process, which gave us a head start at the beginning, but then gave us a disadvantage later on in the epidemic, or in the pandemic, sorry. Well, as you see here in this picture, it's exposure notification action cascade. We will be publishing on it in PLO's Digital Health. Paper got accepted. What you see here is a preprint. And what you see here at the center is the trigger of potential exposures. It's the big star, but it can be triggered by either electronic notification, but also by self-referral or by manual contact tracing, or, and that we discovered in the end happened most, by identifiable contacts that are notified by the index case. So let's say informal contact tracing, outside manual contact tracing, or outside the public health system, like within the family or within the group of friends. Now, last but not least, the higher adoption, I want you to remember it, the higher adoption in it here is the more impact on public health there is, so to prevent forward transmission. Now, some ballpark figures. With a colleague, amongst others, with a colleague, Victor van Wiel is a colleague of Marcel. We guided a European Union assessment of all the European Union applications, and these are some ballpark figures here from the Dutch application. We had 5.9 million downloads, which was a good a number in the beginning of the pandemic, but later on, if people started to double download, etc., this numbers wasn't saying anymore. But what was the case, or what was the most important, is what is the number of active users? And that took, and it's at the peak it was about 3 million, and that means it's 19% of the Dutch population. You see some other numbers, like for example the ratio of exposure notifications, so how many pings or how many electronic notification one entering of a positive test result renders, and in the Netherlands that was between 0.8 to 1.4, so that's a low number. The proportion of diagnosed cases among app users who have previously received an exposure notification was 7.5%, and 77% of the app users who received an exposure notification at that time were not contacted by manual contact tracing. So here we go, we have a little silver lining here. Now, take a look at the key functionalities here in the Netherlands. We only had notify contacts when positive, and you could call, you had a call button to go to a call center and apply for a test. Now, if, for example, we take a look at the German application, we see many more functionalities. So in the Netherlands, we had a kind of a lean functionality application, and for example in Germany there were a lot more applications. It made it more interesting for users to download and use the app. Now, I think more important are the health estimates, and these are estimates because it was very hard to get to the bottom of all the data because of the privacy protection that surrounded whether it was justified or not, that surrounded the contact tracing application and the GAN framework. In the end, I had to use a multi-method methodological triangulation. It took me months and months and months to get to drill down if there was any public health impact. But in the end, we succeeded. It took a lot of energy. So in the end, we could say it's a small appreciable added value. We have an estimated more than half of the people who scheduled a test after notification were also approached by the public health authorities, so the other half was not. We found out that of the asymptomatic people, 3 to 5% that got a notification tested positive on a weekly basis, these numbers, and that was one of our benchmarks. We looked at the prevalence, which was a little below 1%, and we said in the Netherlands, well, if the asymptomatic positive testing approaches this 1%, we should stop, because in that case you could also go around and have some at random testing in the streets. So as long as that was higher than the prevalence, we said it works somehow. Again, 77%, I already talked about, of the people who arranged a test were at that moment not contacted. So digital contact tracing was quicker than manual contact tracing to get to these people, and this way declining the delay. Sorry. But of all contact traced, 1 in 10 was due to CTA contact tracing. So not digital or not manual, but due to contact tracing. The most people applied for a test because they developed symptoms or because they were warned by their family members or friends. Now take this in mind. In the end, we did some model simulation, and we found out that in the Netherlands, the impact on the reproduction number was 0.3%, and that was prior to the big rollout of the vaccinations. Now to the predictors of adoption and adherence, performance expectancy, very important. We found out that the more people trusted it will work or expected it will work, the more they would adopt and adhere to electronic notification. Then privacy infringement, of course, trust and trustworthiness of government, trustworthiness in the way government fights COVID was important. Effort expectancy and self-efficacy, these are typical UTAUG framework indicators. Social influence, what do people in your direct social environment, do they have it or not? And that was, of course, a difficulty because a notification application is kind of invisible. It's on your smartphone. No one can see if someone else has this application. And of course, that was all meant to be, but on the other hand, the social norm was very low. But the effect and the influence of the social norm was high. Now, only adherence variables or predictors are, of course, personal inconvenience, impact of testing, quarantine, and no visitors, receiving no visitors. The higher people perceive that as an inconvenient thing, the lower the adherence. And the same is for symptoms. People who are asymptomatic were less inclined to adhere to the public guidelines, which, is not such a nice thing, because we all know that COVID also spreads asymptomatic. Now, the point is that collecting scientific evidence on effectiveness can be at odds with privacy protection. I'm not saying it is. I agree with Marcel that this is a false this is a false statement. However, many lawyers in many governments throughout Europe interpreted it very strictly, and many colleague evaluators in countries in Europe and I think also in the US it was made very difficult to get to the data. Even if GDPR said it was possible, we always hear, no, it's not possible. So Christoph Fraser and I, we went to the Council of Europe and we had a discussion there. I'll see it on the next slide. Now, of course, privacy is an ethical value, and public debate on privacy is for good reasons. But there are more ethical values, and I took these from the American Public Health Association. They're very good, very nice. My compliments to the US of the ethical framework you set there, about 20 ethical values, and some of them are honestly and accurately reporting health impact, of course. This is also an ethical value, that if you have some interference, you should always be honestly reporting if there is an effect or not. And then you have to know what the impact is, what the effects is, because you have to continuously do some quality improvements. The infectiousness of the virus has changed, so the parameters should have been changed, but none of that happened. But moreover, there's a vicious cycle. No evidence of impact means no uptake. No uptake means no impact, and no impact means no evidence of impact. So that's what we saw in the Netherlands. People started to disbelieve that it works because we couldn't prove it. And they say, okay, well, if you can't prove it, probably won't work. So I will deinstall this application. And this way we got to a downward vicious cycle. And this is why it's so crucial to ascertain the EN effectiveness. So the honestly and accurately reporting health impact, continuous quality improvement, and making sure that if it's positive, that everybody sees it. So it fuels the adoption and adherence. So as I said, Christopher and I went to the Council of Europe. We had a discussion, and then something really cool and nice happened that translated this points of discussion we have here, like the proposition for debate, like offering opt-in for voluntary innovative the data donorship, and do some more research, led to a resolution that anonymously got adopted by the Council of Europe, and here's the link. So this is what I wanted to add to the discussion. Here are my references, the above reference is about research. It's the official source is in Dutch, but I will send Mosen and Bill the English version so that they can share it in the group. And also I will resend this presentation, Mosen, because I made some changes to it. So if you share it to the public, you need to do this. So I will send them right away after I finish this presentation.
Great. We'll include we'll make a PDF of the final presentation that whoever wants to update. In the interest of time, I have a lot of questions, and maybe there are also some in the audience, but we've gone over time, and that is my fault, always the moderator's fault. But we do have a good chunk of time at the end of this session, around 12:15 p.m. California time, and about 2 hours from now, that there's going to be breakout rooms where we can actually have hopefully fruitful conversation discussion. So please hold on to your questions. We're going to just go on a short break, and Alisa is going to put a link for just sharing some of your thoughts about what you've heard. She's going to put a survey link, and we're going to come back in just a few minutes. Alisa?
So just to be clear, while you're breaking, as it were, a quick click on the survey link, and we hope it doesn't take you 10 minutes to do the feedback survey, but helpful to us and helpful to CUGH.
The survey link that I just clicked said that the survey was not available.
I have to agree with you. Says, sorry, we're unable to find this survey. So that makes it actually very quick to fill out, but I suspect we'll get a new link.
No, but we do want a survey that actually you fill out, so we'll fix that and put it back on. Some technical problems.
And I think we've got like a time zone issue here. Is I'm thinking it is 11:10 in both California and Washington, and that says 12:10. There we go. We'll return at 11:09. Perfect. So on the survey, you're welcome to say that the moderators weren't sure where they were.
Hey, you're just jumping to daylight savings time early.
Exactly.
You're ahead of yourself.
And the good news is you're ahead of us too. So that was Bryant Karras, who was our next speaker, who I will be introducing in 3 minutes at 11:09. But first, I'm going to get some tea. Okay, I'm back, and I will clear my throat and make some noise here, because I think we'll get started in just a moment. Actually, I didn't mean literally clear my throat, but that's the way it goes. So I'll assume everybody's back. We titled this session Lessons for Me in Implementation in the West Coast of the US, but what we actually mean is not a contrast to global. We just mean to have a way to show the variety of concerns and approaches within the US. We have 4 speakers with different perspectives on aspects of the EN experience in Washington, Nevada, Arizona, and California. Each speaker is going to share their own slides again. And I would like to go ahead and introduce Bryant Karras, who's the Chief Medical Informatics Officer at the Washington State Department of Health.
Thank you, Bill. And let's see if I can successfully share. Right. Are you able to hear me?
I can hear you, and I cannot see your slides yet.
Hit the right button and pick the right screen. That
looks promising. It's not full screen yet, but it looks like it will be. Bingo.
Okay. So thank you, Bill. And I have 10 minutes, is that correct?
9 minutes, 45 seconds.
So I'm Brian Thomas Karras. I'm the Chief Medical Informatics Officer, CMIO, for those of you who work in a clinical environment, and happily and proudly serving the state of Washington for over 23 years. I'll acknowledge quickly that this work was done on the unceded lands of the Coast Salish people and the Salish Sea, and the background shows Deception Pass, which is one of the most beautiful parts of their ancestral land. Bill, I think, showed this slide earlier in the session, so I won't spend a lot of time on it, but I do want to highlight that for the US and for our collaboration, what began as a very tightly focused group of folks in the Western states quickly grew to encompass much of the US as more and more health departments adopted this methodology. Not all states, and I think the parallel to the European Union, it probably was not all states that participated. So there are parallels there for sure. But what I do want to think about is, how the rewarding aspect of this, Laura West is going to talk about this later in the session, is so exciting to me. The potential and the value of working together. We can go so much farther together than going alone. So my thanks to all the other DNA state and university participants who really contributed to making this an incredibly rewarding experience. From a public-private academic partnership perspective, I think this is one of the best things to come out of the pandemic was groups, organizations, normally competitors, coming together and working with a unified goal, a unified strategy, coming together to put profit aside, to put other motivations aside, and working together to get where we all needed to be. There could be many, many more logos on this page in terms of the overall public-private partnership throughout the course of the COVID pandemic. But these are the groups that really came together and helped us in the US create an infrastructure that we could all partner on. And a couple of particular highlights, the University of Washington, of course, Bill Lober, and the teams in the various schools and institutions within our wonderful partner, the University of Washington. But also APHL, who was instrumental in hosting multiple different cloud environments that we all drew on. And MITRE Corporation, who came up with, in a time that there was no way to evaluate this privacy-preserving technology, came up with an approach and a mechanism where we could reassemble and get some insight and view of what was going on in our jurisdictions. So some of the other contributions I think that we made that we're excited to continue to share and hopefully have set ourselves a precedent is the ability for us to reach at-risk communities in their native language or their preferred language. And we really made this a priority for our implementation. And then to try to decrease the burden for others to follow in our footsteps, shared those translations freely through a GitHub repository so that other jurisdictions could take them, benefit from them instead of having to start from scratch. And we did that with resources such as our the translations that were in the app or in the iOS pop-up alerts themselves, as well as our translations for ad campaigns and social media releases, as well as the the FAQs and the what to do next information that appeared on pages after folks got alerts. So we're really committed to keeping that going. And you can see in the diagram the languages that were actually utilized throughout the course of the pandemic in significant numbers. And it's really exciting to see. Not every language that we translated to got utilized, but many, many, many did, and better to have them there than not, in case that community is hit by the pandemic. So I want to spend a little bit of time, since we saw those amazing numbers from the Netherlands. We didn't quite get up to those numbers, but in Washington, we had more than 4 million total activations, which it's not a one-to-one comparison in terms of the population. We can't know that those are 4 million individuals. It could be the same person activating a dozen different phones. But that being said, we're really excited that's over half of our population for the state of Washington, which is nearly 8 million. Our COVID experience, we had over 1.9 million confirmed cases, for which we were able to get activation codes, or the link, or the ability for the people to activate their device to pay it forward, to notify others, to 1.8 million of those individuals. Over 338,000 started down that process of paying it forward and notifying others. Not all of them took it all the way to the completion of clicking that last button that said, "Are you sure you want to notify anonymously the people who you were near?" But the 237,000 folks ended up generating over 2.5 million pop-up exposure notifications on people that they had been near. And that's way more than we could have ever reached with traditional contact tracing. And then the last thing, calling back to Will's slides from DC, people opted in extraordinary numbers. Over 21,000 people filled out our feedback survey, helping us to understand what the behavior modifications were, what was going on. And I should note that that survey was available in 7 different languages. So I think this is my last, or near last slide before my references. I'm really, really proud of how WA Notify worked in each of our pillars of equity, innovation, and engagement. We made, from an accessibility standpoint, both in multiple languages, as well as for the disability community. From an innovation standpoint, I think it goes without saying that this technology was incredible. And I'm super excited about and see this as a model. The engagement with our community, with our academic partners, with our industry partners, we can't go back. This is a level of work that is beyond, it's changed the playing field. Some of those, in the acknowledgements, I'm going to call out those community partners. I think one of the things that we did that was unique was working with our folks from the advisory, we formed an advisory committee, and I have to thank my colleague Janet Baseman at the University of Washington School of Public Health for chairing that committee, bringing groups together to advise the Department of Health on what to do. And these are the members of the advisory committee, a very diverse group, from at-risk populations that are potentially non-trusting of government, to folks who are very focused on the technology. And was an amazing experience to see these folks come together, come to a consensus, and figure out our trajectory to go ahead. And then I'll finish with just a sharing of the publications from the evaluation team that continues to put out more and more evidence on how this new innovative approach helped us succeed in getting through the. Thank you.
Thank you, Brian. Again, I would encourage people to use the chat, and then we will have some time for questions at the end of this session, as well as the larger group discussion later. I had nothing to do with the advisory committee, but I want to acknowledge the state's and Janet Baseman's boldness in having American Civil Liberties Union as a direct participant in the advisory committee. I think that was sort of a definite attempt to address the concerns about privacy head on. Let's see. So I wanted to point out that of the states in the West, Will mentioned the number of daily visitors in and out of the District of Columbia area. By the way, for those who aren't from the U.S., we often refer to Washington State as the other Washington. It's confusingly named, but nonetheless, we're a long way away from the national capital. Anyway, Will pointed out the flux of daily visitors in and out of Washington, D.C. We have two states in the West, Nevada and Hawaii, who also, for whom travel is particularly important. And so I'd like to introduce Max Wagner, an epidemiologist from Nevada Division of Public and Behavioral Health. And there he is.
Thanks. I'll try to share my screen. Hopefully it works. And then
Looks great, and your audio is great.
okay, great. So yes, my name is Max Wegner, epidemiologist with the Nevada Division of Public and Behavioral Health. And sorry, I think my needs to be. All right. Sorry. I'll be presenting Nevada's novel exposure notification system during the COVID-19 pandemic. This slide is just an overview of our Division of Public and Behavioral Health mission, vision, and purpose, but I'll just get into the presentation now. So Nevada chose to participate in exposure notifications because of its effectiveness in managing the high volume of cases, specifically throughout the pandemic, and as well as the technology being anonymous. One thing that we found pretty cool about the technology is that it works seamlessly with other jurisdictions, which is useful for Nevada's high number of travelers and short-term visitors, which Bill was alluding to just a second ago. And reaching these visitors with traditional contact tracing between states would be nearly impossible, again, using traditional contact tracing. So that made it easier to inform cases or persons that they've been exposed. It's also the operability in airplane mode is also another feature that we thought was pretty good, which means that it works, since it uses Bluetooth technology, it works while the Wi-Fi is turned off for if people are, for example, traveling by airplane.
Max, Rosa just asked if you were advancing your slides. We're still looking at it.
Yeah. Oh, let me see if it works. Oh, is it working now?
Yep, that
I
advances.
was advancing it on the wrong thing. Okay.
No worries.
Sorry. So when we implemented exposure notification in Nevada, we started out with the COVID Trace app beginning in August 2020, which used text notification in an app, a downloaded app. And then Nevada moved to the more recent version of the exposure notification around December of 2020, which is the technology that is embedded in the phone, as well as using push notifications instead of text notifications, which hopefully helped minimize the spam text messages that people would receive on their phones. And in the first 3 days of the exposure notification onboarding, there were over 125,000 devices activated, which is pretty cool. We also wanted to get the word out through promotion. So here's an example of this picture here. It's at the Harry Reid International Airport in Las Vegas, formerly known as the McCarran Airport, but they changed it. I always forget to change the name, but we wanted to get the word out through promotions such as this one at the airport, through press releases from the Division of Public and Behavioral Health, as well as push notification campaigns, and mentioning the technology on our Nevada Health Response website as well. So we just want to go through a quick rundown of the data or the findings in Nevada. So in Nevada, we had more than 3.3 million activations of exposure notifications take place, which was, Bryant was discussing this for Washington in his presentation, but for us in Nevada, this is a pretty big number since our population is about probably barely 3 million, maybe even 3.1 million. 3.1 million people. So we had more activations than we had people that live in our state. And with this, we had more than 540,000 aggregate notifications sent between August 2020 and May 2023, when the public health emergency ended. And daily notifications varied just from a few dozen to more than 5,000 per day. And peak notifications were observed either during weekends, holidays, or special events, which we'll see in a couple of later slides. And we've analyzed data between March 11th and August 31st, 2022. And we found that there was an average of 1,170 notifications sent in on the day per day. So before we go any further, I think we've already talked about this with some of the other presentations today, but people want to know, does exposure notification work? This isn't data from our state, but it is from a publication within Nature Communications, which I think has been distributed around our working group. But this shows that exposure notifications have averted cases, saved lives, and has showed a greater likelihood of testing positive if a person has received exposure notification. So we just wanted to share that the utility here. And then now we'll just get into some Nevada data. So this slide is just an overview of what the interface looks like that we have available through Google Studio. And on this slide, we can see that the total exposure notifications so far is 3.2 million activations, and total exposure notifications sent is roughly 530,000 exposure notifications. So what we also see here is the daily number of new activations and exposures as well. And then what I mentioned earlier is those weekend special events and holidays. For the next slide, so there's a few things going on in this graph here. But so the first one, we want to bring your attention to where the red circle is, the NFL draft. So I know we have people not from the US on the call, but the NFL is the National Football League, or the professional football league in the United States. And the draft is where they select their new players for the season. And this draft did take place in 2022 in Las Vegas. So when my colleague was looking at this data when it was first being analyzed, he was like, oh, there's a spike. I wonder what's going on. And he looked a little deeper into it, and he discovered that, wow, this NFL draft corresponds sort of with this spike in our cases. And then he was hopeful that it would only be like the only spike during the spring and summer. And then all of a sudden this huge spike occurs which is happened on a holiday, Memorial Day weekend, which is a holiday in the United States as well. And then when you look at the spikes between the NFL draft and towards the end of summer, it still is elevated, and we have these spikes that go up and down. And we attributed that to Nevada's the peak travel season in Nevada, specifically Las Vegas during that time. And also these spikes correspond with the weekends also. So again, a lot of our people that come in and out of our state are tourists visiting our state, short-term visitors. So that's what we sort of attribute it to. And we're just, in the next slide, we're just going to drill deeper into the NFL draft data real quick, just to show the utility of what is available for us, exposure notification as far as the tools go. So this top graph here, this is for that the NFL draft. You can see it kind of highlighted in the bottom right here. This shows that during this time, there's an increase in self-reported or home tests positive results, which is interesting. This graph at the lower left hand is again from the Google Studio interface, and it does show the increase in exposure notifications sent during that time. And on the final graph on the right side, you can see that we had our winter peak, and then it went down again, and then it started going up around here when the NFL draft was taking place, and that's actual lab positivity during that time. So we just wanted to show this, just to show the utility of this as sort of a surveillance or help with our surveillance, or I guess a supplementary to our surveillance activities. So in conclusion, we just wanted to say that Nevada successfully implemented a novel, privacy-preserving and user-friendly exposure notification system during the COVID-19 pandemic. And we were able to use the results from this work to regularly update our leadership regarding exposure notifications patterns and trends, like the ones we just went over. And we believe in the future, this technology can benefit other diseases as well, and improve our preparedness for future public health threats, like another pandemic, knock on wood, I guess. And we just, again, want to acknowledge all the our partners that made this all possible. I think Bryant did a good job of acknowledging them as well, but we wanted to re-acknowledge them. And the contact information here for Bruno, who was the biggest part of this in Nevada, myself and our colleague Crystal. So if you have any questions, either we can't answer or we run out of time today, you can email us there. And I think that's it. Oh, I didn't have any control over the animations either. So thanks again.
Thank you. I think the animations are great. No worries there. Also, I wanted to point out a couple of things that Max's talk made me think about. One is Nevada's population as a state is a little over 3 million, 3.5 million, maybe somewhere in between.
Yeah, it's about 3.1, 3.2 million people.
Yeah. And I think you mentioned about 3 million activations. And so I just wanted to say that the kind of interplay between activations, active users, this was alluded to in some of the other talks as well. And like those of us who kind of look at the data know this well, but the interplay between activations, active users, residents of a state, people who travel through your state and choose to switch to your state's EN versus people who travel through your state and don't necessarily switch, but are still part of the interoperable EN framework. That's kind of a fascinating interplay. And one of the things that we talked about in the DNA group quite a bit over the first year or so is like, how do we estimate those numbers? And as I say, I know that came up in one of the talks already, but just it's interesting to look at this state's ratio of activation to population. And we very quickly became aware that different states had different ratios, and in part depending on the amount of travelers that they had. I want to introduce Bruce Helming, who is a physician at University of Arizona and part of the University of Arizona State exposure notification oversight team. So, and has the best backdrop of any of us.
Thank you, Bill. I appreciate it. Thank you, everyone, for joining today. I do want to give everyone a fair warning. I'm not an epidemiologist or a public health person by background, but I've been invited into this space, and I certainly appreciate, and my hat's off to everyone who works in public health. I have a newfound appreciation for the hard work and the challenges that you're facing. So thank you all very, very much. In speaking about kind of our experience, I do have to disclose that I don't have any financial interest in the WeHealth product or our app. I'm also not speaking on behalf of the state of Arizona, the Department of Health, or the university. As other speakers have kind of done, I'm going to give you the summary right up front. I'm a firm believer that exposure notification technology and applications work and were very effective given kind of the short time frame and limitations that we faced, kind of bringing them into the marketplace. We had great experience as we initially rolled out our product with marketing and promotions that worked specifically targeted to our target population. We were in an interesting situation where we rolled it out to a college campus as our initial target population and had a very successful campaign using social media influencers, very much targeted at our young adult population for this community. We also very quickly realized that there needed to be localized messaging. The fact that I'm on a university campus and we have a different set of public health and clinical services available, we want to direct our student population to our health center and not have them inundate the larger community. And so we spent a lot of time and effort creating a tool that would allow that localized messaging with easy oversight and kind of more directly communicate to people what they're looking for their community. We also wanted to simplify the public health oversight. As all of us experienced who've used this technology, it was very cumbersome and a great deal of work to get up off the ground to maintain and support initially, but we have done continual improvement to try and make this process as simple as possible for a public health authority to look at their data, modify their data, and keep that data alive in sort of a real-time mode that we needed to do during the pandemic. We also realized very quickly that both the users of the app and the public health authorities behind the scenes wanted to see the data. For the users especially, they want to have some awareness of what's going on in their community, what resources are available, and have access to that quickly and easily. Certainly as we tried to convince people to move forward onto our platform, providing them with data about what's going on in their community, looking at interactions with the app, kind of notifications and reports was very, very helpful. And as the pandemic was officially wound down by our national leadership, we also started working on other public health hazards that we knew this type of application, this type of technology would be very helpful for. So our experience at the beginning of this, the university started an initiative to get into the exposure notification space. We very quickly found a public organization that was in that space and had technology that seemed to be headed the right direction in terms of privacy protecting and the distributed data model, and that was WeHealth. We also had to bring in the Department of Health Services at the state level to have the ability to use the Google Apple exposure notification system. And so really this was started and kind of has largely been maintained by the university, but we're working with and on behalf of the state. Our initial rollout was very successful on campus. We had almost 50% utilization among our campus population. That kind of dwindled over the course of the pandemic, but for an initial rollout, we were very, very happy with that. The nation of Bermuda also contracted with WeHealth, and they were able to do a very top-down model where that was endorsed by the Prime Minister and the Ministry of Health. And they also saw close to or over a 50% activation and use in their community. And like we've spoken about, they were very much a tourist-driven community. And so that was very actively promoted for individuals who were coming into the nation. And they saw good uptake with the visitors as well. As many of you have known, Arizona faced some significant political challenges, and literally as we were on the doorstep of launching the app nationwide, or I'm sorry, community-wide in the state, we basically were told that the state was no longer interested in participating in this, and we've sort of had to run on our own without state-level marketing support or promotion. In terms of how we designed the communities and our thinking about this, we realized that from a public health perspective, we can be subdivided into many different layers and levels. Where I'm currently sitting, I'm on the University of Arizona campus. I'm in the county of Pima County. I am next to a tribal nation, and I'm also in the great state of Arizona. And each of those communities has different resources, different information about kind of their COVID situation or other public health risks. And we wanted to give the users of the app the ability to kind of specify their home community or to interact with other communities if they were traveling within Arizona or other places. We also had the app rolled out in a senior living community where all the members of that community were motivated and interested in kind of using this technology. And so they created their own community for basically their neighborhood. At the end of the pandemic, we realized that because the apps are sort of neutral to location, we could include the entire nation. And so if you'd like to download the app, it is still available. You can select your zip code and it will give you basic code information about your community in terms of COVID levels and some other data that's available publicly through the CDC. For the users, we allow them to kind of look at that COVID data for their community. We've also started integrating weather alerts based on their community as well. And so we're integrating a data feed from the National Weather Service and looking at other hazards that we can include that are, again, localized to an individual's community, and that's self-selected. Within the community, the Public Health Authority has the ability to create custom messaging and custom links. So in this exposure notification screen, each of those separate entities below has a link associated with that that would link out to the appropriate resources for that community. And so my community, being the University of Arizona, has different testing, different vaccination resources, different medical support compared to the greater Tucson community or my county. And so the ability to customize those at a community level we thought was very helpful. And those are easily copied from a larger health authority if you want to stand by basic recommendations, or you can customize that information at the level of your individual space. For health authorities, they obviously want to see the data, and we had kind of a similar dashboard to what other people have shown. You can look at the county level in terms of activity, see the number of self-reports that have happened and the number of people alerted per self-report. And like many communities, we had double-digit reports per individual user who reported a positive case. The interesting thing for our experiment was that we had very low utilization over the entire state, but even despite that, we still had a significant number of notifications per positive case report that suggests that in individuals who are using the app, their social circles were also people who were interested in using the app and interested in this type of information. So contrary to some authorities where they think that you need large-scale implementation to see effects, we saw actual effects at a smaller scale. We also have in-app app engagement data that is opt-in. And so you could see if the users are clicking around on information, again, about seeking treatment, getting tested, following up to get vaccine information. And those metrics are kind of live, and you can see historical trends. We also allowed push messaging that could be customized based on an individual's status. If they'd received a positive exposure notification, or if they had self-reported, we could send out push messaging to those individuals specifically. In terms of future directions, we all would love to have a communication platform that provides trusted information for public health. And we are trying to kind of create a generic tool for that that still resides in that user's hand or in their pocketbook. We've started using AI to gather, translate, and integrate data. We are also very interested in bringing translations to all of this public health information and looking at ways to use AI to do that. We're also using AI to scrub websites to look for resources. So if you're in a specific community, we can use AI to make sure that information website is up to date, has been updated, and keep an active list of kind of valid COVID data information for people. We're looking at beacons, which are location-specific Bluetooth markers that you could use in large public spaces or large public events to kind of give people notifications based on their physical proximity. And then obviously we're looking at other potential public health hazards. So infectious diseases, air quality, fires, floods, chemical exposures, and other risks. And so hoping to integrate that in all of our future apps. So thank you all very much for joining, and I'll hand it back over to Bill.
Great, thank you. So I think it's interesting that Bermuda, a travel destination, got also a high degree of usage. You said marketing through the Prime Minister's office, and it made me think of two things, or your talk and that fact made me think of two things. The first is that in Washington State, we've been thinking about other kinds of traveler needs as well, such as interoperable health information, which is kind of a rich area outside of the scope of exposure notification. But it is interesting to think about combining needs. And that in turn got me thinking that both WeHealth and the German app that Wolfgang referenced in his talk both have kind of an array of features to enrich the experience of the user and make the app more attractive to them. And one thing I've noticed over the couple of years is that it's been interesting to see different implementations navigate this idea of providing engaging, rich information for a user versus partitioning the experience of exposure notification to emphasize privacy and emphasize privacy. We'll just leave it at that. We've already talked about that a bit. But it's an interesting dichotomy, and it does not directly lead me to the next thing I want to do, which is to introduce Nicole, who's sorry about that. I have a window overlapping a window overlapping a window. Anyway, Nicole Skihan is going to was the marketing strategy lead for CA Notify, which is California's statewide implementation of exposure notification.
Thanks, Bill. Yes, I'm also currently a master's student in the Global Health Sciences at UCSF, and I do see a couple of my fellow classmates have joined, so thanks for being here. And thank you for Alyssa for running my slides. I'm having some technical difficulties today. So next slide, please. So I do want to give the disclaimer, these views and opinions are my own. They are not, do not reflect the official policy of the California Department of Public Health. Again, I'm no longer with them and now at UCSF. So I just wanted to make that very clear, but a lot of these slides were created during my time as a health education and communication specialist on the California's contact tracing team. Next slide, please. So California was, or CA Notify was California's digital exposure notification application. And like the other ones discussed today, it was created on the Google Apple exposure notification system. So this system was free to use. If you haven't had an iPhone, you could enable it in your phone settings. If you were an Android user like me, you could download it for free on the Google Play Store. So this GAIN system used low energy Bluetooth to track how long two users were near each other. And I think we've seen a lot of how it worked. So I'll kind of go over that a little bit. But again, just as a reminder, if one of those users tested positive for COVID-19 and informed the system, exposure notifications would go out directly to the phones of other users that were in close contact with that infected individual at the time that they were most likely infectious. And those that received an exposure notification were provided with isolation and quarantine information as determined by the state. And they were given the steps of what they should do to keep themselves safe. These were tended to be slightly personalized. You were sent to a private website where you would answer questions if you had symptoms, if you had previously been exposed within a certain time frame, and it would walk you through how to get tested and when to get tested, what type of test to take, how long you should stay away from others or wear a mask, and things like that. And the system was really able to complement manual contact tracing because notifications could be sent to somebody that was not personally known to the infected individual. And that was because of that Bluetooth. You know, when a contact tracer investigator calls, you have to be able to remember everybody that you were around and give them that contact information. Using these exposure notifications, it really kind of filled that void. And because it was using that Bluetooth technology, the system was very private. It never stored your name or your location, your personal information, or even the personal information or location of those that you were potentially near, either that you potentially exposed or that potentially exposed you. And I do want to note, I know some of the other ones have had said this as well, but CA Notify was not built on a simple structure. It really operated on several interconnected data systems that included connecting servers, websites, the different systems to send codes and text messages to our users. So it was maintained by multiple entities that collaborated to develop an efficient system. So next slide, please. So CA Notify was launched and maintained, obviously, during an active pandemic. So the system really advanced throughout the almost 3 years of its implementation, and it was changing really as science and policy around COVID-19 progressed. So to start, we had a pilot between September and December of 2020, and this pilot occurred on UC campuses and was mainly run by UC San Diego. And we ran this before the statewide launch. And at this time, we were able to get some feedback from the users. And we found that the tool tended to be seen as very useful. And people did not really report any concerns with privacy. We also learned that the clinical impact was maximized when a code was distributed as quickly as possible following a positive diagnosis. And that really allowed those that were exposed to be notified very quickly and give them ample time to take action. Based on all of the lessons that were learned during this pilot, there was enough evidence to suggest that it was safe to launch statewide. And so we did so on December 10th of 2020. We saw a very sharp in adoption within the first few weeks and over 8 million within the first month. After that, we had on average about 400,000 activations per month. Some of those were reoccurring if someone deleted it and re-added it or got a new phone. And adoption was highest in urban areas and stayed that way throughout the majority of the 3 years. Also, we had a ratio of iOS and Android users that remained about 10-1 the entire time. Next slide, please. So following the statewide launch, we turned to the next phase. We turned to the next phase of the CA Notify implementation, and this involved stabilizing and optimizing the system as the pandemic progressed. So this included updating the system in response to the different variants and the different surges that were coming through, as well as the different state resources that were available. So these advances included increasing the sensitivity of the risk model, which determined who would be considered as potentially exposed. We launched their SMS intercepts, and we launched our marketing and public engagement campaigns that I will get to. Next slide, please. So for the Android and iOS SMS intercept, prior to this implementation, positive cases would only receive a text message letting them know that they should report a positive result after they received a positive test. Of course, this text message did not include specific health diagnosis. It was just very general of, hey, we see you got had a COVID test. If you test positive, please use the system. But this message came from an unknown number. And while we tried to publicize the number and had it available on our website, if anyone was to Google it, we would come up. But we really could see how easy it would be for somebody to not really trust that text message. So we ended up switching to an SMS intercept so that it would come directly from the CA Notify system. And this drastically increased the amount of codes that were claimed by about 75%. And then just to clarify, when we say codes claimed, we're saying that somebody that tests positive used the system to initiate those exposure alerts to anybody that they may have come in contact with. Next system, please. Or next slide, please. At this time, we also began revamping our public engagement and marketing strategy. So this started with the creation of an online and public toolkit. And this kit included a variety of marketing materials, including social media, messaging and graphics, website banners, printable flyers, and even just logos and QR codes in case people just wanted to implement some of our marketing stuff within their existing campaigns. And once we had this toolkit ready, we started expanding our partner outreach to leverage some specific settings that would increase adoption and yield more enhanced benefits. So that's really focused on areas where people might not necessarily know who they're around, like concerts, testing sites, travel hubs. And we also started working with schools in both districts and on university campuses throughout the state. Next slide. And then in 2022, we saw some shifts in the pandemic, including an increased transmission with Omicron. And then again, just more evolving resources around federal and state responses. So here we moved into our phase 3, which is ongoing enhancements. Of the major enhancements, we added a self-reporting feature, which meant at this point, prior to self-report, only those that tested positive from a lab could report a positive result and initiate those exposure notifications. But as we moved to a lot more at-home testing, this self-report allowed those that were using an antigen test at home to also report their results. Excuse me. Next slide, sorry. And so since the sunsetting of CA Notify in May of 2023, we have since moved into the evaluation phase to determine how effective CA Notify and exposure notifications were in general, and how effective they were at supplementing manual contact tracing and investigation efforts. So our evaluation questions have included, how much was it actually used throughout its implementation, who was using it and who wasn't, did it work as we were hoping that it would, and what did users do when they received an exposure notification, whether or not it effectively supplemented conventional contact tracing, and what was the public health impact of CA Notify. Next slide, please. So overall, what we accomplished between its statewide launch on December 10th and its sunsetting on May 11th, CA Notify was activated on over 21 million smartphones and was regularly used by about 8 million people on a weekly basis. We had over 551,000 people notified the system of their positive COVID-19 diagnosis, and this initiated exposure notifications. And over 2.9 million people received that notification and went to the private EN page where they could get next steps on how to stay safe. Next slide. And then we started moving on to our analysis phase. So in analyzing our demographics, which we pulled from user surveys from October 21 to 22. Some of this, there is some selection bias here. It's only those that completed the survey. But we saw that most of our users were between the age of 35 and 65. And we also saw that the majority of our users were iOS users as stated, and they were heavily concentrated in highly populated areas throughout the state. And this graph here of the state, those are the activations within the first 3 months that the program was launched. Next slide, please. And looking further into demographics, and again, there's some selection bias here, but our data is from those that were willing to fill out this survey after using the app. And we saw that the majority of users were white with about 63%, and about 19% of our other users were Latinx. So there is a demographic gap that we were often trying to address, particularly with our marketing strategies. And we also saw that the majority of our users identified as female. Next slide, please. So using our data, we were also able to see that people were following the protective behaviors that we were recommending once they did get an exposure notification and went to that private page. So people were getting tested, they were isolating, and it did help to kind of give them a little bit more clean language as to how to follow California state policy around isolation and quarantine. Next slide, please. We also, in our analysis, compared the success of notifying contacts between CA Notify and CalConnect, which was California's big digital contact tracing system. And so we saw that CA Notify was able to reach more people, especially since the infected individual did not have to personally know that anyone they may have exposed. And this difference in the amount that we were able to reach really increased during major surges in the pandemic. Next slide, please. Our analysis also showed that people received their codes and used their codes more often with CA Notify, and this meant that they were initiating those exposure notifications much quicker with CA Notify than that was recorded with CalConnect. And again, we saw an upward trend during COVID surges. Next slide, please. So based on some of our preliminary modeling, and this is both from UC San Diego and Oxford, an Oxford UK model that was released in the early days of 2021, our estimates show that during the first few months, there were potentially 18,000 to 24,000 cases that were averted due to exposure notifications in California. Next slide, please. So looking at how exposure notifications actually enhance traditional contact tracing programs, first one, if you could, it was generally faster. Those notifications went out within a few hours of somebody having a positive result, either from a lab or from an at-home test. It was able to, again, detect the undetectable. You did not need to know the people that you potentially exposed to send them an exposure notification. We also sent a lot more notifications. It was able to detect more exposures per infected persons, especially if we increased the risk model throughout some of the major surges. It was cost efficient. It operated with little operating costs and fewer staff than that was necessary for case investigation and contact tracing efforts. And it really, our data is showing that it did supplement CICT. They were able to work together and implement the system. And so it allowed for CICTs to interviews to focus on high risk situations. I think that's it. So thank you so much.
Great. Thank you very much, Nicole. I love the way you slipped up and said next system, please, when you meant next slide. And so I
sorry about that.
I just want to
I'm really just promoting the next EN system that was
exactly.
hopefully
So, you know, I think one of the things that we're all really interested in is this idea of what the next system should be, you know, how to understand and build on the positive aspects of the way that exposure notification was perceived by individuals, by public health at the state and federal level, and how it's perceived by our tech partners, particularly Apple and Google, on whom we have depended for the integration of these tools within the operating system. So I think that those kinds of value points are partly what the next two presentations are intended to be about, and certainly the, you know, just good topics for discussion. And so with that, it's 12:02. We are almost on time. And so I think I will close, and I think I'll let Alyssa, I think Alyssa's going to pick up and talk about a brief elicitation of discussion group topics.
Yes. Before we get into that, I did want to share our results from our slide from earlier. Thank you for bearing with us as we figured out what was going on with that poll limit. But we have a pretty good group of folks calling in from all over the US and the globe today. So I just wanted to show where everyone is from. It's great to see the turnout. And then also, we are going to head into a quick break. But before we get into that, I did want to open up, actually, Nicole, if you could open up the Zoom poll. So we're going to have breakout groups later that are going to be based on specific topics around exposure notification. So if you're around for the end of our session, we would love to have you join us in these discussions. But we also want to make sure that we are talking about the things that you're interested in, which is why we're launching this poll now. Which EN topic are you most interested in discussing during our breakout groups? So go ahead, choose the ones that you're most interested in. And we'll make those groups based on what our results show us. We also have the session evaluation. If you have to take off, no worries. But we do invite you to please give us some feedback on how our session is going today. You can scan the QR code, and we'll also pop that link into the chat as well. All right, we will come back at 12:10, and we'll see you all very soon.
Always fun to see the horse racing between the topics. Alyssa, I'm just looking at the as the numbers coming in. Does it also allow the co-hosts to put their vote in the system?
Unfortunately, it does not.
Okay. So we can't really manipulate the findings even if we want to.
It's very unbiased in the case of we as the presenters cannot.
That's great. See y'all in a few minutes.
All right, everyone, it is 12:10. We will go ahead and get started with our third and final part of today's agenda. I'm going to go ahead and end the poll. Thank you so much for everyone who participated. And I will hand it off to Rosa, who will moderate this section of our session today.
Thanks, Alyssa. So I just briefly want to introduce both Alyssa and Laura. Alyssa's needs no introduction, but Alyssa Bercasio from she's a project coordinator at the University of California, San Francisco. And Laura West is a public health informatics specialist at the Washington State Department of Health. And they're going to lead a discussion to introduce our breakout sessions, talking about ongoing research activities and considerations for the future.
Thanks, Rosa. I'll go ahead and get us started on future considerations and research that we're looking into now. Specifically, I'll be talking about Project Identify, which is our digital exposure notification priorities for global outbreak response. Can't remember if I introduced where I'm where I work, but Rosa did, UCSF. I'm a project coordinator there, but my roots in public health really started at the beginning of the COVID pandemic. I was a contact tracer and later moved on to coordinating the training program for contact tracers and case investigators for San Francisco, working mostly with community health workers and HIV test counselors. And now I'm here working in EN. So decided to stick around for a little bit longer. So as we've seen today, from all our presentations that we saw from around the world, when properly designed and implemented, EN systems present a really low-cost, user-friendly, privacy-preserving, and also scalable intervention that can significantly expedite the identification and notification of exposed contacts really early in an outbreak. But what we've also seen is that there hasn't really been a systematic approach to compile and synthesize the evidence regarding the facilitators and the barriers to EN implementation and user uptake. And also not really a concerted effort either to establish a consensus on prioritizing improvements to the technologies that we have. So this is the gap that we're hoping to fill with this research study that we are working on. And our objective really is to take the findings from this study and use them to inform the design of future EN applications, provide guidance for EN implementation policies and best practices, as well as contribute to shaping the research agenda for the future of EN technology. And we hope to do this through 3 specific aims. The first aim, to identify barriers and facilitators of EN implementation, characteristics of EN systems, as well as considerations for adoption, and doing this through a targeted literature review and systematic review. We also have our second aim, which is a Delphi survey of EN experts, to be able to establish the priorities for the improvement of the future of EN systems, which are informed by the areas and themes that we have found from the first aim through our literature review and systematic review. And then the third is to have small group interviews to really elicit EN expert input on how to operationalize the priorities that we established from our Delphi survey, as well as develop policies and guidelines to ultimately disseminate and impact the future of EN application priorities, as well as those policy and guidelines and the research agenda. So the first aim, which is the targeted literature review and systematic review, we've already done the literature review. And what we've seen is there's a lot of great information out there on the successes of EN implementation, but there's also a lack of consensus as to how to best configure these systems. Also learned that there is not really a defined standard of measurement when evaluating an application's impact. And we've also established that baseline list of EN-related topics and themes that require further consideration and looking further into. Some of them include the functionalities and design characteristics, the applicability to other infectious diseases, global partnerships, as well as privacy and accessibility. Which brings us to our systematic review, where we really wanted to perform a comprehensive review of the literature to further identify the successes and barriers and any other considerations that we need to look at when improving our EN systems. Our second aim is to establish those priorities, which we would like to do through the Delphi method. And if you're not familiar with the Delphi method, that's okay. All it really is an iterative process to establish consensus amongst a group of experts. It's a survey that is done in 3 rounds where we ask our participants to rank the importance of certain EN topics to establish priorities. And then we'll take those responses, analyze them, and update the next survey and implement the second round. And we'll do that for 3 rounds. And here we are really reaching out to any domestic and international expert in EN technologies across the many different the sectors with experience in COVID-19 and pandemic response. For survey topics, these are the same topics that are coming from our literature review and systematic review, and I've listed them here. And finally, we have our third aim, which is really to operationalize the priorities established in aim 2 through in-depth interviews with our EN experts and outbreak response experts who participated in the Delphi surveys. And through these interviews, we aim to gather further insights on how to take these prioritized items and how to best translate these priorities into actionable improvements for existing EN systems, and also how we can effectively communicate these findings to policymakers and guide development of these policies. And that brings me to my next slide, is that we are currently recruiting participants for Project Identify's Delphi survey. So if you are interested and you are experienced with EN technologies and you have experience in COVID-19 pandemic response, we're really looking to you to help us gather your ideas and your knowledge and be able to establish those priorities on how we can continue to improve EN for future outbreaks. So if you're interested, I have a QR code here, so please go ahead and scan it and express your interest, and you'll receive an email in a couple days next week from me. I'm inviting you to take our survey. And I see Nicole has popped it into the chat. And with that, that's the end of my presentation. So thank you so much for listening. And I'll hand it back to Rosa for our next speaker.
Elizabeth, I thought that you and Laura were going to be more in tandem, so I'll briefly introduce Laura again before we head into our breakouts. So Laura West is a public health informatics specialist at the Washington State Department of Health. She coordinates efforts for the agency's digital public health tools and has been instrumental in meeting our digital notification lines. Welcome, Laura.
Thanks, Rosa. Hi, everyone. My name is Laura West. I'm a public health informatics specialist at the Washington State Department of Health, and I'll be talking about the value of EN systems in a very broad sense, and many of the speakers today have already touched on some of these points, so I will be keeping it brief. And as mentioned before, we have a multi-state community of practice for EN in the United States called the Digital Notification Alliance, or DNA for short. And I have had the privilege of facilitating the DNA calls for the past year and a half. And one of the work products that's coming out of this group is a white paper or review paper on ways that we think EN systems in the US have provided value. And then we'll be looking at evidence for each category of value to see what metrics we have available. And we're considering value provided not only to public health, but to communities and individuals, as well as smartphone technology companies. And we hope that this exercise can help us summarize lessons learned and think about the future opportunities for other types of public health alert systems. And this is still a work in progress, but today I will share a list of the values we've come up with so far. The first way they provide value is in their flexibility. While the original systems were developed for COVID-19, the risk score settings and thresholds for notifications are configurable, and future iterations might be able to provide notifications of other diseases or even other types of exposures. And we also think that the risk scores could be adapted in the future to be more targeted for individual risk factors or risk factors for certain vulnerable groups. The second way is in their timeliness and reach, which improve outcomes at both the individual and the community level. As others have talked about today, EN systems have shown to reach more contacts and do so more quickly than traditional contact tracing methods. And this earlier notification can lead to earlier treatment, which can then reduce the risk of severe disease, hospitalization, and death. And the early notification and broader reach of EN can also interrupt the disease transmission, which averts cases and saves lives. And timeliness and reach are also important for other types of public health notifications. The third way is through privacy-preserving user empowerment. As many have talked about, EN systems provide users with the next steps that they should take, and they provide this information in the language that the user's device is set to. And users who test positive are empowered to anonymously notify their contacts, thereby protecting their communities, which is an empowering action to take. And all this is done with a high level of privacy protection. The fourth way EN systems provide value is through the ease of use to turn on and keep on. Apple and Google created the EN Express platform, which public health authorities in the US could implement with a relatively low lift and no cost from Apple and Google, which many jurisdictions chose to do. And on the user side, EN was free for users, and because it was integrated in their smartphones, it was easy to turn on, and it ran in the background once it was activated. The fifth way that EN systems provide value is that they provide a service to smartphone customers and therefore to the technology companies. The sixth way is in the ability for public health to directly reach the public in both an accessible and an acceptable way, which is through smartphone notification, like I said, in the user's preferred language. And because this communication is automated from the public health authority, it is thus lower cost compared to other methods like contact tracing. And the public can also provide additional information to public health through those surveys that are offered in the EN system that Will and Bryant spoke to earlier. The way that EN systems provide value is by providing a new source of non-diagnostic early warning data for use in surveillance and forecasting. And much of this is still untapped, but we're excited about. And then number 8, the 8th way is around interoperability, which again, many people talked about today across borders. In the US, most of the EN systems used national servers, which made the systems interoperable, protecting people who traveled between states and also giving people the opportunity to use the system, even if their own state didn't offer EN. And then lastly, not inherent to EN systems themselves, but as a byproduct of the implementation in the US, we've also seen the added benefit of that multi-state collaboration, as well as collaboration between the public, private, and academic sectors. And with that, we've seen the exciting development of that new evaluation methodology. So that was quick, but hopefully a good overview of why we're all very excited about EN systems and want to keep discussing opportunities to continue leveraging this technology. Thank you.
Laura, thank you very much. And Lisa, Rosa, for introducing this section. Just want to take a minute and thank every speaker. I learned a ton myself, and I really appreciate also our colleagues from Europe who stayed up late. I think it's past 8 p.m. Their local time. And before we lose more participants, I would like just to introduce our next section, which is our breakout rooms. The three top leading topics that we identified, and I think Nicole is going to put them in a chat in a second. But evaluation and measuring impact that Rosa is going to moderate. The second group is going to be integration with public health practice. That'll be moderated by Holly Howard, and EN for other diseases that Laura West will moderate. And I'm sure Bill and myself are I'm going to be having a hard time to pick which topic to go to, but maybe I split my own time between two. And if we don't find so many people in one group, maybe they can just we collapse the groups to maybe two. All right, Nicole, can you just say a minute how people can choose which group they go to?
Sure. And I will launch them right now.
You're having trouble finding the breakout rooms. If you click more at the bottom of your screen, you'll see a breakout room option. And then you should be able to choose which breakout room to enter.
When I launched it, it opened up a window for everybody, hopefully. People are starting to move.
So people need to click on the breakout rooms, scroll down, and then you see the name of the breakout room, and then you click on the join and self-assign yourself to which room you want to go to.
Yes.
There's still a few people that haven't moved, so if you need to be, if you want to be manually assigned to a room, let us know. We can send you there.
If you have a trouble to find out, you can maybe put your name in a chat and the room that you want to go to, and we can help that.
Most coming back at 55, right?
Yes, and I'm going to public health integration room and suggest that we integrate it with evaluation and measuring impact.
So it's pretty fitting for the topic.
You want to move those two into one?
I think if Mosen hops into the breakout room and just tells them, so they're not all of a sudden moved.
Okay, yeah, looks like everybody's jumped. Still have a few people in here. Do you need help being moved? Or is this all CUGH?
I think so. Sarika, could you pause the recording until we come back?
Sorry, this is the lull from CUGH. I'll pause it right now.
Thank you so much.
I'm so glad that there are still survivors of this call.
Well, and I'm glad that I know that the closing remarks are brief.
Well, we can make it a little bit longer, but I just wanted to maybe just say a few words. I think that the just for me the differences in experience in a few jurisdictions, especially the kind of theme between what some of our colleagues in Europe experienced, there were more similarities, especially the states who are active, like DC or Massachusetts, California, Washington, Nevada. There seems to be a theme that things worked, but also I want to also emphasize the survivalship bias, because the fact that many more states have started in the US, not all of them stayed long enough or spent or showed interest in evaluation. So that is something that I'm just kind of observing. There were some issues about compliance and what people do once they get exposure notification. And the experience of Netherlands is a little bit different than the experience of, say, a few of the states in the US. Not a huge difference, but the surveys that we have done post kind of EN surveys shows a slightly more promising kind of actions. The other thing that we kind of briefly discussed about in the room that we attended, the integration and evaluation, I think one of the takeaway messages for me was things happen, at least for us in my experience, happen through time. So there was evolution of how things were perceived at the beginning, and there were some concerns about the privacy. There were some concerns about how things are going to go. There's not a lot of precedent about this technology. There's not a lot of evidence before that. So often the governments and constituents related to the government, they tend to be a little bit more cautious at the beginning. But over time, there was a build of trust, and that things moved in a slightly more promising direction. I'm going to pass it to Bill so he can actually add his remarks. But what I would love for us to be able to continue this discussion, we'll reach out to those who provided their email address so we can set up follow-up meetings. I think that would be good for those who are interested having more concrete discussion. I think this would get this discussion, this presentation, give us a very good foundational ground, and also informing our March panel, which Bill and I are going to reflect on and think about how we better organize it. But also the hope is that we are able to have a venue where we can come back together and have a discussion.
Yeah, and I really don't have much to say other than what I put in the chat, which is like, thanks to particularly the UCSF folks and Nicole for well, who's now a UCSF folk also, but but for supporting this activity. And I don't want to recap anything, but for me, it feels like we can say all we want about how unpopular it is to talk about COVID these days, or how, exposure notification, Apple and Google have kind of, this isn't the top of their list right now, but I think it is really a good idea to maintain this perspective and expertise on the use of new technologies, because we're going to need new technologies again. And I think exposure notification is a great example of something that was helpful. And thanks to CUGH, that's the other thing, is like, there's a great opportunity for us to expand our perspectives and engage. This time around, it's interesting. Two folks from Nigeria were on the call, so that was good. Anyway, so that's it. I don't know. Thanks for staying up late in Europe and joining us, Wolfgang. That was great. It was nice to meet you.
Yes, thank you. Thank you, everyone, for joining. Thanks to CUGH, our DNA colleagues, Bill, State of Washington. You guys have been always getting us organized. Really appreciate that. And by all means, I think we can keep the Zoom on in case people are interested in just chatting. CUGH allows us. And if anyone else who's remained on the call would like to come off mic and say anything, please, by all means. I'm happy to stay longer.
I'm just going to come off mic to say I have to go off and pick up my kiddos, but this has been great. It's really nice to have this ongoing engagement, and appreciate all the participation.
Yeah. And we'll see some of you guys, some of you folks Tuesday at the next DNA call. And, maybe we'll send something out saying that if other CUGH attendees are interested, maybe we can make some room in an occasional DNA call for a larger group. That would be good. We still want to keep that focused on the state public health agencies for the moment, I think. But anyway, see y'all.
We should think about the new acronym, GNA, maybe Global Notification
Something
Alliance.
that doesn't have notifications in it, and something that doesn't have alliance in it. We'll work on that.
We'll work on that.
Hey guys, see you. I'll be
Yep.
off. Okay, bye
Thank
bye.
you.